Test 1, 2. Mics are off mute. And we are live. And 5, 4.
Good evening, everyone, and welcome to this evening's webinar presented by the College of Optometry at Western University of Health Sciences. I'm Bob Gordon, and I will be your MC for this evening. Before we get started, I would like to introduce Michael Bradford, who is the person who's made this webinar possible through his audiovisual skills. Michael?
Thank you very much. I am Mike B., your engineer for the evening. Just want to get a few housekeeping rules out of the way before we get started. This webinar is, your audio settings have been disabled, which means that we cannot see you or hear you, but we know that you are online. You should be able to hear us fine. You should be able to see our video and view our content with no problems. If you have any problems, please use the Q&A box in the top left corner of your screen to let us know what's going on. If this may be a little bit after the fact, but try to log in the future with your full name and an email address so that you get proper credit for joining this session. For Q&A, again, if you are joining on a laptop or computer, there's a Q&A box at the very top of your screen on the left side. Just press that Q&A box, and then you can type in your question, and those questions will be addressed at the end of the evening. You also have the opportunity to send those questions anonymously if you choose to do so. Mobile device users have the same ability. For your mobile device, you just tap your screen. You will see Q&A show up in the top left corner. On the far right, it will say Ask. Tap that Ask button, and you can enter that question, and we will receive that as well. Those questions go directly to the moderator, and only the moderator. And again, those questions will be answered at the end of the session. Thank you again for joining us on another fantastic ride, and we hope that you have a wonderful journey. Have a great evening.
The purpose of these webinars is to both educate and familiarize you with Western University College of Optometry, its faculty, and our eye care center. Just a couple housekeeping items. First, remember to keep your microphones muted during the webinar. At the end of the webinar, we will open the floor for questions. At the conclusion of today's webinar, and actually it will be tomorrow, Maria Espinoza, our Director of Continuing Education, will email you a link for the post-test so you can obtain 1 hour of continuing education credit. It is indeed my pleasure to introduce our speaker this evening, Dr. Daniel Kurtz, whose talk is entitled Emergency Head Pain. Dan graduated with a PhD in psychobiology from the University of Michigan, Ann Arbor, and with his OD degree from the New England College of Optometry. He completed a sabbatical in neurooptometry at Brigham and Women's Hospital in Boston. After serving as a faculty member at his alma mater for 25 years, he left in 2007 to become the Associate Dean of Academic Affairs and Professor of Optometry here at Western University of Health Sciences College of Optometry. It is indeed my pleasure to turn the program over to Dr. Kurtz.
Good evening. Welcome, everyone. I'm going to talk today about emergency head pain, or headaches that are really bad. And there's a reason for this. So the idea is to recognize when a headache is an emergency. With all kinds of neurological conditions, the etiologies range from benign to really, really terrible and life-threatening. So when a patient presents double vision, eye pain, any kind of pain, head pain, headache, I believe the first thing you have to do is rule out emergencies. So don't be doing an elaborate workup on a patient who's about to die or who might die in the next couple hours. So the treatment plan or the therapy for pretty much everything I'm going to talk about is a referral. And it's an urgent referral. It's the kind of referral when you say to a patient, you know, you're going to skip the cruise this weekend. you're going to the emergency department. So what I hope you'll get out of this is to recognize those emergencies and make those referrals, because we all know that as optometrists, we see lots of headache patients. Headache is extremely common presentation to optometrists, and it's an extremely common event in people's lives. So we all see headaches. We've almost all had headaches. One of the games I played as a professor was I would poll my classes, class of 100, 120 students. How many of you have never had a headache? Well, there's one. So that's the second person who's raised his hand in 30 years. So I calculate in my non-random unscientific study that the prevalence of never had a headache is approximately 1 in 5,000. So in other words, people get headaches. We have headaches. Your patients will have headaches. And so you got to be able to rule out the really bad ones. You simply would be irresponsible to refer every patient who ever came in with a headache, and yet you don't want to miss one that's an emergency, that's life-threatening. So the next hour is about recognition. When is it an emergency? And if it's not an emergency, then that's the topic for another night. So the goals for the audience, for the students, the members in the audience: distinguish emergency from non-emergency, achieve a tentative diagnosis of the emergencies, so you can make a better referral, some information that's pertinent. And finally, we'll go through the 10 red flags. This has become a part of mainstream literature in headache practitioners. Now, every primary care doctor, every neurologist, we know, oh, here are the 10 flags. So we'll review that at the end, and you'll see there's a connection between the 10 flags and the emergencies. What makes them 10 flags is they suggest or point to one of the headache emergencies. So this is what I hope you'll get out of this evening. Now I have to say, every part of the body can experience pain. Technically, the mouth is above the neck. It's part of the head. But I'm going to skip over eye pain. I'm supposed to get this done in 50 minutes, and eye pain alone is worth a couple hours. So basically, we're skipping that part of it, and we're going to talk about pain around the eye or in the head. So it's a headache or periocular location. So your patient says it hurts someplace above the neck, let's say above the teeth. One of the first things you want to do is say, point to it. Where does it hurt? And that will guide us. So here's multiple presentations. This is what they look like, maybe. And here's what we're going to ask. How rapidly did this pain come on? So rate of ascent, how quick? Secondly, how bad is it? And we try to rate pain, can scale it from 1 to 10 or 2 to 10 and even numbers. How bad is it? And third, perhaps the most important of these three questions is, have you ever had this kind of pain before? A very important distinguishing characteristic between emergency pain, the kind of diagnoses we'll be talking about, and one of the more classic chronic headache syndromes, which tend to occur over and over. That's what makes them chronic headache syndromes. So how fast did this pain come on? How bad is it? And have you had this kind of pain before? And we're going to ask a fourth question later, where is the pain? Can you point to it? So the emergency conditions, the things you got to worry about, typically have an acute onset. You wake up with it, or over the period of an hour or two, I suddenly started to experience this. So rapid onset, characteristic number one of all the emergencies. Now, as I go into more detail, I'll point out some exceptions. It's not 100%, nothing is 100%. But the dangerous conditions tend to have an acute, rapid onset. Secondly, they tend to be severe. The pain is bad. Third, it's not a recurrent or chronic condition. First time ever. I never had this kind of pain before. fact, as you could probably tell, you can triage a lot of these over the telephone, so that you don't have to do a big workup necessarily. So it came on very quickly. Wow, this really hurts. And may I have headaches all the time, but never one like this. That's when you get worried. So what do we mean by severity? So pain is subjective. Everybody's pain is somewhat different. Every 6 is different for different individuals. But still, we ask patients to scale it. If you can rate this pain on a scale of 1 to 10, how bad is it? Is it a 1? Is it a 5? Is it a 10? Now, you know, this is not always easy for patients to do. They don't ask themselves this question, but you're going to ask them, just how bad is it? Now, if you're in the presence of the patient, if you see the patient, you have a lot of additional information. So here's a well-known, this was designed for children and nonverbal patients, but you use this when you're assessing pain. So person on the left, this is all of you in the audience and the people sitting here in the room drinking wine. They're all very smiling. We have no pain. That's, of course, is 0, and that's not one of the things we're discussing today. And then you look at the faces. These are the Wong-Baker facies, they're called, and it's only got 5 scales of pain, so we double the numbers. So if the patient is the number 2 there, hurts a little bit more, that we would scale as a 4. So it is still we take the Wong-Baker system and we make it into a 10-point scale. It was originally a 5-point scale. So you look at the patient. So I had a patient who said, how much does it hurt? Oh, it's an 8. But then you look at her, you look at her affect, you look at her face, her posture, you think, she looks like a 2 to me. So you have to add that in to your judgment of just how bad of pain it is. What is the severity? They rate it. You have to do some rating as well. But the emergencies, the dangerous conditions, are going to be off to the right. These people are in serious pain, and it's unambiguous. In addition, you have to ask and be very careful with these 2 things. These are things we worry about with head pain. Trauma, malignancy. Malignancy anywhere, what do we worry about? It can go to the brain. Highly vascular structure, this concerns us. Recent trauma. Trauma is it can be nonspecific, anything. And the brain, again, especially in older senior citizens, which is defined as anybody who's 5 years older than I am or more. With trauma, even a simple fall, a bump on the head, can lead to cranial pathology. So history of trauma or history of malignancy, you gotta ask if it's not obvious. So those things are in addition. Then locate the pain. So where is it? There are these 3 locations, and you ask them, take your finger or your hand and point to it. Where does it hurt? Does it hurt here, here? You got 2 hands, is it here? Is it here? Is it here? Is it here? So that is a very important piece of information. Now, most of the things we're going to talk about is going to be cranial pain. They're going to go like this. It's going to be kind of all over, but not necessarily. So you ask them, where is this pain? Point to it. Try to draw a circle around it. And that's also very helpful. So we have rate of onset, severity, is it a unique event, history of trauma, history of recent malignancy, and where does it hurt? Once you have that information, you're off to a good start. So let's look at the periocular conditions. Where if the patient points to something around the eye, not right in the eye, topic of another lecture, not all over the head, but around the eye. And there are really 2 conditions, 2 diagnoses that are emergencies where the pain is right around the eye, not necessarily in it, not up on top of the head. That's orbital cellulitis and giant cell arteritis. Now, one of these is easy. Here's a picture of orbital cellulitis. Look at that eye. Moving right along. I mean, you look at that eye, you think, holy smokes. And it's puffy, it's painful if you touch it. There's often something coming out, and it's even painful if the patient moves his eyes around. So pain on eye movement, this is orbital cellulitis. The patient is ill. What is cellulitis? Itis is inflammation. Patient's sick, and it looks bad. And if you must, you try to distinguish orbital cellulitis from preseptal cellulitis, which is not an emergency. In the worst case, you send them to the ER. Better safe than sorry. That's one of the rules with pain. So patients in distress, and this is a referral. This patient usually admitted, they get IV antibiotics because the orbit has direct communication to the cranium. It goes through the superior orbital fissure into the cavernous sinus, and an actual infection can spread into the cavernous sinus. It's inside the cranium. It's past the blood-brain barrier, and it can kill the patient. So that's why orbital cellulitis is an emergency. We worry about it. You can't miss it. But again, it's one of those things that stares you in the face. So you should be able to see that pretty easily. Giant cell arteritis is trickier. Also an emergency. Now, what's wrong with giant cell arteritis? So it is kind of what the name implies. Actually, giant cell, not so much. Arteritis, yes. Inflammation involving arteries, usually mid-sized arteries, sometimes large, but mid-sized arteries are all over the place. So what do we worry about? Ischemic optic neuropathy, a stroke of the optic nerve. And this is arteritic, because it's arteritis, as opposed to non-arteritic, which is all the others. So this is a disease of the elderly. It's a growing segment of the population. Again, this is a misprint. It should say greater than 73, because I'm 68 now. But statistically speaking, greater than 60, that's really when we have to worry about this. So the older the patient, the greater the risk of arteritis. Has an erythrocyte sedimentation rate, or we call it the SED rate, is elevated. Now, there are all kinds of formulas. I don't see any point in trying to memorize what's normal for a female or what's normal for a male. If it's up there past 50, it's elevated. That's a risk factor. That's a problem. The temporal artery, because we sometimes call this temporal arteritis. Temporal artery, which is up here around your hairline. You got two of them, one on each side. May be palpable. That means if you run your fingers across this part of the patient's head, you feel something. It feels like there's something under there, not something alive, just like a string or a rope, a little piece of twine. And if you feel it yourself, which I encourage you to do, a couple of our audience members are doing, you should be able to run your fingers right across there. You don't really feel it. If you get just the right spot, you should feel a pulse. That's the temporal artery. Now, to be giant cell arteritis, you really want a biopsy of that artery. So biopsy is exactly what it says. Somebody goes in, they open up the skin, and they cut out a segment of that artery. The good doctor, it's kind of a point of pride among surgeons. How much of that artery can you get? A good one gets at least an inch. So if it's a quarter of an inch, yeah, because the inflammation, it's not uniform all along the artery. It can be here, it can be there. It may not even be in that particular mid-caliber artery. But still, that's the place, because you can do just fine when you cut that one out of there. You suture it off. And if it's inflamed and you see giant cells in the artery and it occludes that artery, that's the end. That patient has arteritis, giant cell arteritis. In addition, it is an itis, so it's inflammation, and it's a systemic disease. So people feel unwell, they lose weight, they're flu-like, they can have fever. Again, it's an itis, there's inflammation in the body. For many, many years, I wondered what jaw claudication is. What the heck is that? I don't know what claudication is, but what it basically means is when you chew, if you put your fingers back up where the temporal artery is and you pretend to chew, you'll see there's motion there, there's stretching. And so if the temporal artery is inflamed and you stretch and pull on an inflamed tissue, it hurts. It's uncomfortable. That's what jaw claudication is. Finally, and this is actually important to remember, and that is that giant cell arteritis is associated with this other condition, polymyalgia rheumatica. Now, why is that important? Well, polymyalgia rheumatica, PMR, may not kill you, but if a patient comes in with this diagnosis, and I saw a patient like this, polymyalgia rheumatica, admitted to the hospital on a Thursday, all kinds of tests, prod, taking blood, woke up Sunday morning, blind in one eye. And the people who were managing the PMR were not thinking giant cell arteries, and they should have been, because that's about a 50% incidence. If a patient has PMR, 50% of them are going to be positive for giant cell arteritis. So here was a patient who completely lost vision in one eye unnecessarily, if they had just made that connection. So it may or may not look like this. You can't always see the inflamed artery, but you might. And then this is why this is an emergency. This is what we're worried about, of course, that when the artery strokes, whichever artery it is, usually strokes around the optic nerve head, posterior cerebral arteries, and gosh, it's neural tissue. Remember, it's an extension of the brain, dead in 4 minutes. So, and there's no recovery. So therefore, patient comes in, head pain, could be unilateral, could be bilateral, over 60. You gotta think giant cell arteritis and consider a referral. And it's an emergency, and we treat massive systemic steroids just on suspicion. You can still get the biopsy, you can still make the diagnosis after the steroids have begun. The temporal artery is blocked up, it'll still be blocked up. So you treat on suspicion, because once the nerve is gone, it's gone. There's no recovery. And usually patients are not even hand motion. They have a dark world through that eye, and it's a very high rate of stroke of the other nerve. Now, if we were preparing for boards, we'd try to remember 30% after 1 week. So I was just reviewing these numbers, and it's like 3/4 within 30 days if you don't treat. So to me, that's a very high risk of the other eye, the other optic nerve going, and then the patient's no optic nerves. So respond quickly, get them treated. The dream, the goal is to be suspicious, get them in, get them treated and diagnosed before they lose even one nerve. But if a nerve is lost, then it's an even greater emergency to protect the other nerve. So here's what you can do. Well, I love colors, I'm color coded. So here's my green slide, which is a technique slide. Practice finding the pulse. Practice finding it on yourself, those 3/4 of you who classify as normal, or you can practice on your patients. Now, if you don't feel the pulse, it doesn't mean that you have giant cell arteritis, but it's a good idea if you can kind of find it where it is. Practice on patients. Until your hairline recedes, it's really right around the hairline. It can be slightly behind, slightly. But you find it, and then when you suspect someone, you feel for the pulse. And like I said, if you feel a string, you run your fingers across it and say, shoot, I feel like there's something there. That's suspicious. That's not diagnostic, it's suspicious. And remember, giant cell, we refer on suspicion. We're not going to let our patients stroke out. So temple pain, unilateral, bilateral, patients over 60, think of this. And here's a word, I made this word up, UPO. It's because when I was a professor, I'm still a professor. As a professor, I get to make up words. And UPO means until proven otherwise. So, GCA, UPO. Okay, that's our bottom line with suspicion. Okay, now, if it's not periocular, it's cranial. We've said it's not the eye, it's not around the eye, now it's the head. And that doesn't mean we're off the hook. On the contrary. So here's giant cell arteritis, number 5, often included among headaches and headache syndromes. It's pain in the head. But we're going to spend the rest of the time mainly talking about these 4 clinical conditions. Aneurysm, subarachnoid hemorrhage, meningitis, and encephalitis mainly, and malignant hypertension. So these are emergency conditions that can show up with acute onset, severe pain like I've never had before. That's what they share. So they tend, the location, if the patient can point to it. It's going to be up on the head, could be frontal, could be the whole head. And that's useful to say it's not an eye problem, it's not periocular, but it doesn't really give you the diagnosis. So the location is not what tells us what's wrong. So again, just remember the 3 questions. So review, onset, severity, frequency. Have you had this before? How bad is it? And how rapidly did it come on? And now these are good 3, I believe in these 3 questions. You should remember these 3 questions, but also we'll talk about some exceptions as we go along. So high severity, rapid onset, the description, usually steady. Headaches, there are 3 general categories of the pain. Stabbing, pounding, boom, 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 or steady or vice-like. So for these conditions, the pain is going to be steady, vice-like pressing. Accompaniments. Is anything going along with this? And this may or may not be helpful also. Besides the headache, what? And that can be anything. Any kind of neurological weakness, tingling, one side, the other side, nausea, throwing up, feverish, any of these other things. You want to find out what's going on in addition, what accompanies the pain, or maybe there's nothing. So let's talk first about an aneurysm. So an aneurysm is a little balloon. Usually they occur at the junctions of arteries and with a predilection for the high pressure arteries, which we'll get to in a second. A lot of people go through life with small aneurysms. They're thought primarily to be congenital condition. There's a little weakness, usually at the junction where one artery joins another, 2 high pressure arteries, and it's just a little weakness there. It's like a weakness in a piece of plumbing, but it's not made out of metal, it's made out of tissue, and it just kind of balloons out. So a lot of people carry these around with them and for many, many years. And as long as that's all you got, it doesn't kill you. People can go to their grave with a small aneurysm. But if it should pouch out at some point, get a little bit bigger, it starts bumping into things, then it becomes symptomatic. As we bump into things inside a confined space like the skull, what happens? Things don't move out of the way. They have no place to go, and it starts to hit pain fibers, and that's when you get the headache. So if the aneurysm is now ballooned, it could still be small. It's amazing. It could be a centimeter. It's like it's still a tiny little balloon. But if it balloons out and hits things and stretches or bumps into the nerve fibers, you get this rapid onset, severe pain. Now, in addition, there are often going to be other neurological signs or symptoms that go along with this. So as we see, I have a picture in just a few minutes. Because the majority of aneurysms occur around the circle of Willis, and because of the equipment, what else is located at the circle of Willis, we often get eye, vision, signs, oculomotor nerve. This is a pupil-involving oculomotor nerve. As the pupillary fibers are toward the outside of the nerve, and the aneurysm is coming from the outside, bumping into the nerve. So the pupil is affected, doesn't work right. Patient's not doing too well. This is a mass, a space occupying something or other inside the skull, and this get an elevated intracranial pressure and people get sick. They throw up, not feverish. This is not an itis, there's no inflammation, but they're not doing very well. And so you frequently get focal neurological signs depending on what the aneurysm, what the mass is bumping into. And finally, often change in mental status. Now, I remember for many years being terrified by this symptom, change in mental status. Oh gosh, do I have to remember now? Did they count from 100 backwards by 7, or do they count by 6? And do I ask them who the current president is, or I have to ask them who the first president was? And forget all that. Every time you interact with another human being, you are assessing their mental status. You just look back, think back. You're in the supermarket. You're walking your dog in the park. We are so adept at noticing when people are off. Something. You can't necessarily describe it. But you have a patient on the phone or talking to you, and you'll know when their mental status is not right. They're going to look funny. Their posture will be funny. Their speech will be different. Their rate of response will be off. So this, to me, is the low-hanging fruit. You can easily become suspicious if they're not right somehow. That's called change in mental status. Severe rapid onset headache. They're acting a little dopey. That's enough for me. Go to the emergency room. So that's a neurological sign, mental status. So here's the circle of Willis. It's a beautiful picture of the circle of Willis, but it didn't have all the labels. And I had to draw in the approximate location of the oculomotor nerves. That's that green line there. Usually they're not green in real life, but that's where it's located. And if you look, and I'm not going to try to point because I'll mess up the slides, but there's the optic chiasm and the optic tract. In this drawing, we're looking from the bottom up. It's like we're lying underneath the car and we're looking up at the base of the brain. And anterior is to the top, posterior is to the bottom. All those red things are arteries, and they're high pressure arteries. So the internal carotid has a big job to do. It pumps into the circle of Willis. And as you can, if you look around, every place there's a junction from one artery to another, that's a risk site for an aneurysm. Those are the weak points. And so you see the weak points are located there around the optic chiasm, the optic tracts, the optic nerves, the oculomotor nerve. I didn't draw in the 6th nerve and the 4th nerve, but they run right along near the circle of Willis, and that's what happens there. So you're likely to see with an aneurysm, especially oculomotor nerve problems, which is the pupil, the eyelid, you get ptosis, and eye movement disorders. That's what the oculomotor nerve does. And we'll talk about that a little bit more in greater detail, but that's what this is all about. Circle of Willis, high prevalence for aneurysms, bad aneurysms located near all these visual things and eye movement things that we test on a daily basis. Okay, that should be easy. It balloons out, it hits the oculomotor nerve, the patient says, I see double, you see the pupil isn't working properly, they've got the severe rapid onset headache, boom, they're out. ER, get imaged, that's good, you've saved a life, but it's not always that easy because the aneurysms, as I mentioned at the outset, can be there for a long time. So what's it doing all this time? It's just a little thing, not doing anything. And then it may puff out a little and may actually shrink back. So it's this funny kind of space-occupying lesion, which sometimes it seems to be there and sometimes it's not. Sometimes it's like the glass that falls off the table. Sometimes it's just at the edge of the table. So when you have headaches, with this presentation, you gotta check the 3rd nerve extra carefully. Because you're not in a hurry, you're really, really looking at the pupillary response. Not so much pupillary escape or afferent pupillary defect, but you're looking at the response of the pupil. You compare one eye to the other. Trace those eye movement patterns carefully. Make sure the patient isn't experiencing any kind of double vision or misalignment. You may not report double vision. Do the eyes keep together or are they slipping? What else do we check? We check for ptosis. That's another thing that can happen with the 3rd nerve. How do you check for ptosis? You take out a ruler, a PD ruler, and you measure. I always told my students, optometry. If it can be measured, you should measure it. So don't just look at the eyes and think, yeah, that's close enough. Measure the palpebral aperture and see if there's symmetry or asymmetry. Any suggestion, get worried. In fact, I would almost think if you've seen the patient before and you saw no suggestions of oculomotor nerve problems, and now you have a headache patient who's got even a suspicion, you think you're not sure the oculomotor nerve's in perfect condition, that's a referral. Remember, we're going to save a life here if this is actually what's going on. So, oculomotor nerve. Now, the other thing we do, so oculomotor nerves, cranial nerve 3. Another thing we're really experts at is cranial nerve number 2, which is the optic nerve. And if the optic nerve is hit, something's pushing against it, like a little balloon, what are you going to see? You're going to see visual field loss, possibly, probably, and you're going to see visual acuity loss. So even though the fibers that serve visual acuity go down the core of the nerve, they're in the middle, they're not going to be directly hit. But if you imagine a big cable with a bunch of wires in it, or a bunch of tubes, and something's pushing on the outside, well, it's going to deform and push all the way in. The fibers for visual acuity make up a big proportion of the optic nerve. So even if they're not hit directly, they're going to be hit by whatever is hit, and you'll get reduction in visual acuity and possibly an afferent pupillary defect. So we're the experts on vision. Check VA, you pinhole, you look for afferent pupillary defect, and check fields. Again, best corrected vision's reduced. It wasn't reduced before. That's a focal neurological sign. Patient got bad headache, reduced vision, refer. Patient got a bad headache and you detect some kind of peripheral field effect, that's a referral. That's the focal neurological sign. So here's more bad news. So we may get no signs at all. The signs may come and go. They may not be there when you actually see the patient, and not all aneurysms produce headache. And why is that sad? It's sad because don't we wish every serious problem produced dramatic symptoms? We'd have a lot fewer people dying, but not always. So as I said at the beginning, aneurysms are typically congenital. People with aneurysms can carry them a long time, and as they stay small, they're not symptomatic. But then, what happens? Trauma, some severe stress, the blood pressure spikes, some combination of these things. And then that little balloon, okay, Michael, is falling off my lap. And I caught it, but how do I go back to, I know it's down there, so okay. It's down there somewhere. No, don't take me back to the start. Okay, just in case you were sleeping, you should be waking up now. I'm awake, I know that. Okay, so something happens, there's an event, and now the aneurysm starts to bleed. That's a way bigger problem than just a little balloon. So that's when a lot of them are detected. So what is it? What do we call it when an aneurysm bleeds? We call it subarachnoid hemorrhage. It's the location of the circle of Willis, and most of the arteries are underneath the arachnoid layer. Remember, arachnoid, pia below, dura above. It's close to the brain, and blood comes out. And the blood in the subarachnoid space can go all over subarachnoid space, which includes down into the spinal cord, all around. Well, blood is not supposed to be there, so that's when you get the headache, elevated intracranial pressure, and big symptoms. So that's when a lot of the aneurysms are detected, when they bleed. Now that's a real emergency. You don't have hours, you have minutes to save this person. So this is what we're hoping to avoid. So something happens such as spike in blood pressure, trauma, aneurysm bleeds, or sometimes just spontaneously it balloons out and opens up. Big problem, subarachnoid hemorrhage. This is a killer. So, classic case, it's sort of, in a twisted sort of way, this is what you hope will happen. Oh my God, worst headache I've ever had. My head hurts everywhere. It hurts when I move, I can't, my neck hurts. Why does the neck hurt? Because the blood is going through subarachnoid space down the neck into the spinal column. It's not supposed to be there. And other signs, but no fever. So it's severe rapid onset. It's bad. Patient is really a mess, but they're not feverish. That's easy. Again, patient calls you up and says, wow, this is the worst headache I've ever had. I fell down the stairs and it's like, wow, I can't believe, and I'm nauseous. And you could say, well, okay, go to the emergency room. Don't stop by the office. And here again, this is the problem with subarachnoid hemorrhage. It can present in a lot of different ways. So the headache may not be so severe. Darn it. The headache may even come and go. How can that be? Well, if there's a little bleed, it bleeds out, symptomatic, it could stop temporarily. Blood pressure spikes, there's a bleed, blood pressure comes back under control, bleeding stops or slows. Patient says, well, I had this really bad headache, but kind of went away. It was probably nothing, right? I just need new glasses. I'll be fine. Ignore, go on the trip. Okay, so it comes and goes. And pretty much all these headaches have the potential to respond to analgesics. But analgesics are non-specific. So the fact that you take ibuprofen and the pain goes down or you feel a little better, unfortunately, that doesn't prove that you're out of the woods. Of course, if you have a hemorrhage and you take old conventional aspirin, that'll help with the diagnosis because then it'll bleed worse. We really don't want that. So the fact that it responds to analgesics is not, you're out of the woods. Still could be a problem. However, suspicion, head trauma. Well, trauma can do anything, but that's when you worry, oh, what if there was an aneurysm? What if there was this weakness? Now we jostled the head around like crazy. Now we got this severe headache. That's a problem. And any neurological sign. So headache plus severe acute onset, ever had this headache before, any neurological sign, those are referrals. It's like, but says any neurological sign, what if the patient is in the chair and they present this way? How do you know if they have neurological signs? Well, you can ask them, hey, do you have any focal neurological signs? And you might find a patient who can answer that. But to me, it says, no, you really need to test for focal neurological signs. So we have some green slides. Well, in every eye exam, every comprehensive eye exam, I assume you're testing cranial lobes 3, 4, 6, and 8. How do we do this? We look at pupils. That's controlled by the oculomotor nerve, cranial nerve number 3. Check for ptosis also. Check EOMs. The oculomotor nerve controls 4 out of the 6 pairs of muscles. So when you test pupils, you're testing 3, 4, and 6. And by the way, one of my trick questions is, how many cranial nerves are there? And the trick is, oh, there are 12, right? On old Olympus. No. The trick answer is there are 24 cranial nerves, because when we test them, we always compare function on one side to function on the other. We never just look at one, we look at the nerves in pairs. That'll affect eye movements. We don't just look at pupils, we compare one pupil to the other, same thing with eyelids. So here's normal, equal rounded responsive, directly and concentrically, no ptosis, full, extensive, smooth, accurate. Those are eye movement things. And don't forget, it's not just 3, 4, and 6, but 8 as well. The vestibulocochlear nerve also has a big impact on eye movements. Defects in the vestibular system tend to give rise to things like nystagmus, not gaze palsies or diplopia, but you're supposed to be looking for that when you test ocular motility. So you're testing, here we got 4 pairs out of 12. We're really off to a pretty good start doing a neurological analysis. We can test cranial nerve number 5. Now you can read books on this and they'll take 12 pages to describe how to test the trigeminal nerve, but this is kind of a poor man's quick and dirty. Chair side, you take a piece of tissue. There are, again, 3 pairs of dermatomes on the face. And this is just a drawing of the ophthalmic nerve, maxillary nerve, mandibular nerve. The only trick to note is that mandibular nerve, the dermatome does not wrap around onto the neck. That's a different nerve. So you test up on the face. And what you're doing is you just touch it lightly, compare what you feel on the right side to the left side. Again, we're testing in pairs. I've seen people take their tissue and drag it across the forehead in both directions. Does it feel different when you get from one side to the other? And that's a test of the oculomotor nerve. The normal is symmetry. Facial nerve, also very easy to test. Raise both eyebrows. Some people you can push down. Can they raise them? Clamp your eyes shut tight. You're looking for asymmetry. Puff out both cheeks. Should be symmetrical. Alternately grimace and smile. Grimace is like this, the down, smiles like this. And you're looking for any kind of asymmetry in the muscles of facial expression. That's what the facial nerve does. Testing hearing. You rub your fingers. These things are not always high tech. Start out, when do you first hear my fingers? Now, you have to try to make the sound equal, but I'm hearing them both now. They sound about equal. I hope that's symmetrical. If it's not, don't tell me. But this is what you do with your patient. And you're looking for an obvious asymmetry. This is not a hearing test, but you're looking for asymmetry, something obvious. 8th nerve. Hypoglossal nerve, everybody's favorite nerve, controls the tongue. Stick your tongue out. You say to the patient, stick your tongue out. I don't know, should I demonstrate this? There you go, uninhibited. And if one of the 12th nerves is affected, the tongue will deviate away from the affected side. One muscle's weak, one muscle's strong. So these things are not high tech. And that's the 12th nerve. And if you stop and count, I think we've now tested 2, 3, 4, 5, 6, 7, 8, 9, or 12. So 9 out of the 12. That's a pretty good start. We've assessed mental status. We do this chair-side test of the pyramidal system, the system by which the neocortex controls the muscles. So look for, you have them hold their hands out like this. You look for 2 things. Does one rotate? That's pronator drift. Ooh, that's not good. Does they stand there? Does one arm drop? If you want to be more invasive, you push down on their arms while they pull up, and you look for asymmetry in power. And you can do the same thing with the legs. You can push on the shins. As an optometrist, I always told my students, you can touch your patient anywhere outside the strike zone. So the strike zone starts about the armpits, it gives off at the knees. So yes, you can push on their shins. You say, straighten your legs. You push back. Is there an obvious asymmetry of power? And that's a test of the pyramidal system. Non-specific test for intracranial pressure. I love this slide. You look for papilledema, spontaneous venous pulsation. You've already looked for a 6th nerve palsy. These things are non-specific, elevated intracranial pressure. They won't tell you where a problem is. They won't even tell you if there is no problem for sure. The last patient I had who had a brain tumor, it was negative for all these things. But every once in a while, this will tip you off to something, to field or not to field. All right. So atypical subarachnoid hemorrhage, nausea, vomiting, syncope, fainting, seizures, headache, and any of these, you gotta worry. And I've never had one of these before. And then you get suspicious. And is there a good alternative? So there are all these other things, topic of other lectures, migraine, tension, neuralgias. They can produce severe pain. They can be accompanied by nausea. So you have to consider these, but you should consider subarachnoid hemorrhage because that's the killer here. Diagnosis number 3, meningitis encephalitis. So usually bacterial, can be viral, itis, inflammation. We all read about this in the paper at college campuses. Severe, widespread, rapid onset. Patient's sick. In fact, the patient looks a lot like he's having a subarachnoid hemorrhage. And the big difference is with an itis, you get inflammation, there's fever. With a subarachnoid hemorrhage, there's no inflammation. And they can have stiff neck and everything, but they don't have a fever. Now, you know, to me, it's like, are you really going to sit there and take the patient's temperature? Probably not. But they might say, they can tell they have a fever. Parent or spouse comes in and says, yeah, he feels kind of hot to me. That would suggest an itis, a meningitis encephalitis, rather than subarachnoid hemorrhage. Otherwise, they're pretty much the same. Headache, and either one is an emergency. So if you can't tell them apart, it really doesn't matter. You still know what to do. Malignant hypertension, I'm just going to breeze past, not very likely. Blood pressure doesn't have to be that high. But again, today, people are so conscious of blood pressure, hopefully you'll never see this. Okay, so we have a headache, acute onset. This is the classic word, worst headache I've ever had. Remember the third characteristic of emergencies, unlike headaches you've had before. So they use superlatives like worst, never had one this bad before. You've just got to think, in the absence of any other information, this is a subarachnoid hemorrhage until proven otherwise. Got to get them in, get them imaged. Better safe than sorry. The worst headache. So I used to put this on all my tests for my students, the giveaway question. Oh, doc, this is the worst headache I've ever had. Subarachnoid hemorrhage. So I promised you the 10 red flags. And some of these we've already talked, most of these we've talked about. Number 10, high blood pressure, unexplained vomiting, fever, stiff neck. Number 3, I bolded there, positive for neural signs. Again, one of those 9 cranial nerves, pyramidal system, anything not symmetrical, gotta be suspicious. Bad headache, positive neurological sign, just get them seen. Gotta cancel your cruise, you're going to the ER. Now, some of these are not quite so obvious. First headache in a patient over 51, that really doesn't mean first time you ever had a headache. It means the first time you had this particular type of headache in a patient over 50. Now, that's a red flag. I would not consider that an automatic referral because it kind of depends. Depends on some of the other characteristics of the headache. Headache that's getting worse and worse, well, I don't know. But these other things, like the fever, the vomiting, we've really talked about. Those are evidence of elevated intracranial pressure. So that's the famous 10 red flags. If I were in practice or when I was seeing patients in community health centers, I just printed this out and I taped it up on the wall someplace. So just to remind me how to be careful. And more recent literature, the reddest of the red flags. Any neurological signs. This is an accompaniment of the headache. Now it says they're not equal to aura. An aura is something we typically associate with migraine headaches, the subject of another lecture. But aura is a neurological sign, but that's not what we mean. If it looks like an aura, walks like an aura, smells like an aura, yeah, it's probably an aura. That's not a new neurological sign. Other than that, anything you test, you're not sure, even a change in mental status, that's a neurological sign. That's an emergency. Recent malignancy, I don't know how recent it has to be, but patient has malignancy and cancer. If the cancer has spread, you have to worry. And if you don't worry, your patients will worry for you, because every patient with a bad headache thinks they have a brain tumor. But if they've had cancer, it's even more likely. And finally, red flag, if there's been head trauma. I put the word potential in there because sometimes patient won't be able to tell you if if they fell off their bike, a lot of times there's a blackout period. Don't know quite what happened, but somebody should tell you. So it's the potential for head trauma. That's something to worry about with a bad, severe headache, recent onset. When do you order imaging? Well, I personally never was in a place where I could order imaging, but anything. You have an index of suspicion. This is kind of where we apply the sleep at night test. Can I sleep at night? Am I really not worried? Or do I gotta worry? So, depends. Reminder, patient comes in, like my patient who told me her pain was a 6 on a scale of 10. Her face looked more like it was a 2 or a 4. I said, how long have you had this headache? 3 months. It's like, well, she's probably not gonna die in the next day. So that's a little bit reassuring, just a little. Once you've ruled out all of the above, so remember, patient presents, first, rule out emergency. Make sure they're not gonna die on you. Then you can proceed with your workup, which, oh, darn it, I was gonna tell you, but we're out of time. Questions? I wasn't really gonna tell you, because I did run out of time. This is exactly how much time was planned. So anybody wanna jump in? Uh-oh.
Thank you, Dr. Kurtz. At this time, please type in questions you may have, and I will forward them to Dr. Kurtz so he can attempt to answer them for us.
Attempt, yes. The operative word is attempt, please. Easy questions only.
And what is an easy question?
One that I can answer.
Okay.
It's late. Those of you on the East Coast, thank you for signing in. It's 10 o'clock on the East Coast.
Okay, Dr. Kurtz, you mentioned that subarachnoid hemorrhage may present with subacute symptoms or symptoms that come and go. Why is that?
Well, you have to think about where subarachnoid hemorrhage comes from. Something's bleeding in there. Probably the number one source would be aneurysms. And if it just opens up, you're going to have a severe headache, rapid onset. But sometimes those little weak points, those little balloons bleed out a little, they leak. And so as the blood goes out, the patient's symptomatic. If the blood should stop, if the hemorrhage should stop, if it clots, then the symptoms may resolve. So it's because of the way subarachnoid hemorrhage happens. If we're talking about something like a trauma, and we've really ruptured a blood vessel or an artery, it's not going to come and go. It's just going to be there. So it depends on the exact natural history of that patient at that time.
Thank you. Next question. Palpebral fissures are usually normally asymmetric. How many millimeter difference is significant to be called atosis?
Thank you for that question. I don't know. What I would say is this. Here's my what I would like to say. What's normal is normal for your patient. So as you see patients, it's a good idea to mention the palpebral aperture. So a patient walks in, he's fine, I'm just here for a checkup. It wouldn't hurt to measure them. You look, and sometimes we look at a patient, his pupils are normal, his eye movements are normal. Totally not in distress. You say, well, there's a little asymmetry there, but he's normal, so I'm just not gonna bother to record it. I click on my pull down menu, it doesn't say slight A. So you just blow it off because you know it's not a problem. To me, that's a good time to be measuring and recording. Then if the patient should come back and you see, oh, well, this one's 7.5, this one's 8, but it was like that 3 years ago and 5 years ago, then you know it's not a problem. But if you've looked and measured and it was 9 and 9, and now it's 9 and 8.5, I'd be a lot more concerned. So it's sort of, there is a lot of variation. Say the same thing about pupils. How much anisocoria is normal? Well, physiological anisocoria is present in about 60, that's 60, of the population if you really can measure it down to the pixel. So it's when you first notice those little asymmetries, that's a good time to record. Don't just blow it off because you know it's not a problem. And then when the patient comes back, you have a baseline.
Okay. And this question actually comes from one of your students who graduated in 2005.
Well, you know this already.
If the patient has symptoms that are of concern and it is determined that they are to be referred, what is the process of referral if the patient came to the exam alone? In other words, send patient to the ER themselves or request an ambulance for transport?
Well, I got to say, if the patient needs an emergency referral, I would dial 911. I would not expect them to drive. And particularly if the presentation is the kind of thing we talked about tonight with severe headache. A lot of these patients feel unwell. They're worried, oh gosh, I must have a brain tumor. That's not a good person to be driving around. It's like, you know what? Your insurance will cover it. We're going to dial 911. Depending on where you are, you know, you can put them in your car, but I don't think that's a good idea. Get an ambulance. That's what they're there for.
Okay. If a patient presents with an alarming headache, how do you go about facilitating imaging if you do not have privileges for ordering? Do you refer to the emergency room?
Well, I think what I would do to facilitate, you do have to refer. They're 911, they're on their way to the ER. But you can try to send information with them or call ahead to the emergency room. And you can get it done if you say to someone at the emergency room, look, I'm referring a patient to you with a bad headache, and I'm concerned that this patient has an aneurysm or a subarachnoid hemorrhage, and you put that in an email and you follow up, they're going to have to pay attention to you if you have even a tentative diagnosis, particularly if it's one of these things. So I don't know about facilitating imaging, but I think the more specific you can be, the more worried you are in your language, the greater the probability that they're going to respond to it and get the patient imaged as they should be.
Next question. For the non-emergency cases that need referrals, do we send patients to their PCPs, to a neurologist, a neuro-ophthalmologist, or to whom? I'm worried due to insurance issues, patients might not be able to see their primary care practitioner or neurologist promptly.
Well, I guess that's tricky, but I would say, how worried are you? On a scale of 1 to 10, how worried are you? You know, the PCPs are usually the gateways. And if you're really, really concerned, you can talk them into seeing the patient that day or within a week. So I usually call, you get somebody on the phone and you tell them how much worried you are. You know, this can't wait a month. This can't wait for next available. And if you use some of the words, you can get them motivated too. We're concerned. I'm concerned about this patient. This patient is not able to function. There's a change in mental status, something like that. So that's what I hope part of the value of this lecture is to give you some of those buzzwords so you can get them seen quicker. You can get them imaged quicker if it's at all appropriate.
Actually, speaking of buzzwords, let's just take one final question. You didn't spend any time on migraines, yet they can be severe and have a rapid onset. How can you distinguish this from one of the other emergencies?
Okay, that's a good question. I'm glad I wrote that question. That's a good question. All right, so first of all, real migraine can be just as bad, can be accompanied by nausea, can be accompanied by focal neurological signs. So it can look a lot like some of these emergency headaches. The big thing is, I've had this kind of headache before. So is this a recurrent headache? Oh yeah, I have migraines. About once a month I get these. They should be similar. Yeah, it's about the same. That's characteristic of a migraine. So then you know it's not a one-time, never had this before. Well, what if it's the first migraine? What if you're dealing with an 18-year-old who's had their first migraine? Well, A lot of headache specialists would say, first migraine needs a workup. They need to be imaged, they need to have blood drawn, first migraine, because you can't always tell just based on signs and symptoms. So the answer is, if it's the first time, you're probably going to treat them like an emergency. But if it's recurrent and it's the same pattern, then you pretty well know what it is, then you can be more reassuring.
Thank you very much, Dr. Kurtz, for a really entertaining and information providing session. One last thing, when you receive the information from Maria regarding the post-test, she'll provide you with information on how to evaluate tonight's webinar. We would really appreciate your feedback. I hope you'll join us for our next webinar on May 6th for a slightly different presentation. In a roundtable format, we will present a discussion on what to consider or do when someone with a visual impairment asks you to complete a Department of Motor Vehicles driving report form. Thank you very much and have a good evening.